We have a great session today. So hello, everyone, and welcome. I'm Lee Yates, co-facilitator of the TBC at UBC Network and clinical associate professor in UBC's midwifery program in the Department of Family Practice within the Faculty of Medicine. Today, I'm joined by Christy Newton, my TBC at UBC Network co-facilitator. Christy is the Associate Vice President Health and also Associate Professor in the Department of Family Practice in the Faculty of Medicine at UBC. Thank you for joining us today for the network event. Before we begin, I would like to acknowledge that the UBC Vancouver Point Grey campus is located on the traditional, ancestral, and unceded territory of the Musqueam people, and the UBC Okanagan campus is located on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. I'd also like to recognize that UBC's activities take place on Indigenous lands throughout British Columbia and beyond, and that you are joining us today from many places. I'm grateful to the traditional owners and caretakers of these lands. I'm joining today from the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Please feel free to share the lands from which you are attending in the chat.
Thanks, Lee. So welcome, everyone. I am joining from what's now called Port Moody, the traditional unceded shared territories of the Coast Salish people. And before we dive into our topic for the day, I'd just like to share a little bit about UBC Health and the TBC at UBC Network. The TBC at UBC Network is coordinated and supported by UBC Health, which is under the Office of the Vice President Health. And the aim of UBC Health is to help address the complex challenges affecting the health and well-being of individuals, communities, and societies. And it does this by facilitating dialogue and collaborations across disciplines, across faculties, across campuses, with external partners and communities to improve the ways we train people, we develop knowledge, and we shape policy to ultimately address inequities and to improve the systems that foster and support health. The TBC at UBC Network is meant to be one of these opportunities to bring together health professionals and leaders, community members, academics, and policymakers to share innovations and bring forward questions important for the evolution of team-based care in British Columbia. And the network aims to complement province-wide efforts like HDC to enhance team-based care in British Columbia by focusing on the academic niche of education, research, evaluation, and knowledge translation, and by enabling participants to learn from each other and to connect each other's efforts.
Thanks, Christy. Before we launch into today's session, those of you who are familiar with our network events know that we open with a poll to see who's joining us in the conversation today and who's in the room with us. So if you have a moment, I invite everyone to select who you are or what perspective you bring to the conversation today. Fantastic. So we have faculty and staff from UBC with us. We have some clinicians and folks from health professional associations. Our largest population, a quarter of the folks in the room today, are bringing a health authority, administrative, or government perspective. And we have some community members, patients, researchers in the room with us as well. So thank you for taking that time. Moving into today's session, our session today will explore how interprofessional primary care teams can measure the positive impact of their efforts. The Health Data Coalition is joining us today to highlight 3 examples from across the province where team efforts were recognized for their clear impact, as seen through the Health Data Coalition Discover application. We're looking forward to their presentation very shortly. For today's session, we're going to begin with a presentation from the Health Data Coalition. Following the presentation, we're going to transition into 3 smaller group conversations, each addressing the same set of questions. And then finally, we'll come back and reconvene as the larger group at the end to share highlights from each of the breakout rooms and discuss how to continue these conversations going forward. And so now, with a warm welcome, I'll hand over to Dr. Cole Stanley and the Health Data Coalition team. Thank you for joining us today.
All right, thank you so much, Lee and team. I'm just going to get my presentation up here. You were able to see that? All right, so I think we're supposed to do a bit of a self-introduction. So my name's Cole Stanley. I'm a family doc. I'm in the downtown east side at the Hope to Help Clinic. I think I saw Belinda on the call as well from here, clinic manager. So we do team-based primary care for marginalized and vulnerable populations. Actually, coincidentally, I think part of our team has just reached out to team-based care at UBC to get some expertise as we're trying to improve our team functioning. And so we're kind of working at this at multiple angles right now. Unfortunately, my clinic doesn't have HDC yet. So also a note to Belinda, hopefully you're listening and you can help me make the continued case to figure out how we can get it for my clinic too. Yes, and so I do, in addition to primary care, I'm the quality and innovation lead here, medical director for Health Data Coalition, and I do a bunch of quality improvement related things. Really, the overlying aim of my work besides the clinical, I think, is to get really robust quality QI into our daily practice and really have that approach and a team-based care approach. Gail and Kathy, I'll maybe get you to briefly introduce yourselves.
Maybe I'll jump in. Hi, everyone. My name is Gail Grout. I'm the executive director here at the HDC and recognize a number of names and would love to meet a number of you as well. I'll pass it over to Kathy.
Hi, happy to be here today. My name is Kathy McGinnis. I am manager of community engagement and learning programs at HDC, part of our field team, the clinical services team. My goal is to really integrate data into quality improvement, supporting that and bringing in education where it's appropriate. So you're looking at data in context of what you're learning. So look forward to today's session.
All right, thank you. And yeah, I guess I've given it away that we're kind of recycling this talk because it is not the FPSC core committee today. This is the UBC team-based care talk. But what we've really done is distill down what we do at HDC to some key elements and just a few examples of how this tool and has been used and how our organization is able to support this sort of work. So I'm going to quickly go through that, and then most of the time for the breakout group discussions, talking about the potential uses for this and yeah, so hoping this prompts a good discussion. So we've called this "What's Inside This Black Box" here. All right. So a lot of us on the call, we are either in family medicine or we work in systems that support primary care. And so I see Christy in a little box here. And so we know there are plenty of joys of working in family medicine, right? We're able to see patients in the good times as well as the bad. We're, for example, seeing at the birth of this little girl and all the happiness around that. But we know it's not all the joys, right? We're there for the more sorrowful times as well. So, for example, maybe this woman suffering from congestive heart failure exacerbation in the hospital yet again. Or this woman and her family, she's getting chemo for her advanced cervical cancer. Or this woman suffering her first heart attack after struggling with diabetes for many years. So between those joys and these more sorrowful moments, this is where a lot of our potential work happens, right? So, and we think sometimes if we can do our work well, the proactive preventative work of primary care, we may be able to prevent or delay a lot of these not so happy outcomes, right? So that's where primary care sits. So that's me working in primary care. That's, Omesh, our board chair, another primary care doc up in Prince George. But it's not just the physicians, it's the people we work with. We want to really improve this primary care here to get better outcomes for our patients. Same with Christy, same, Ben working in team-based care. I think this is why we're all doing this type of work, right? To ultimately get better outcomes for our clients, whether we're, trying to do better education, find out research that gives us better ways of treating people. This is the overlying goal. Same with Brenna, UBC, whoever's on the call here. I think we all agree this is what we want to do. So we all want to improve, right? Shared goal. How are we doing? This is a hard question. This is a kind of a data question, right? If you talk about quality improvement, we need some measurement of how we're doing. Traditionally, what can we look at? We know when people are born, for the most part, the birth registry, the death registry. So I've got two databases. That doesn't really tell me a lot about in the in-between. We've got discharge abstract database. So if they go into the acute care system, we can get some information about what happened there. We've got PharmaNet data, get some idea of medications they're on and they've filled. Billing data, so you can get a bit more information about maybe a bit what's going on in primary care. If you work in primary care, you know all the limitations of that and how many times people are just labeled as having general symptoms and all the issues with that. But for the most part, what happens in primary care traditionally has been a black box. So all the stuff we do in primary care, mostly these days through our electronic medical record, is traditionally not available to see how we're doing as a broader system. And I would say that is until now. Okay, so with HDC, we can kind of open up that black box. I'm going to give you a few examples here. So heart failure. So there are the new guidelines for heart failure, which basically give you a set of 4 medication classes where we know we get much better outcomes if clients are on these medications. That being said, we know that most or many clients are still not on these optimal therapy. So we had Daisy Delay, a cardiologist, do a project with a PCN pharmacist going into primary care and offering the pharmacist review of their clients with heart failure and offering some titration and optimization of their medical regimens. So this was a team-based care PCN pharmacist working in consultation with the cardiologist, but mostly working with the family docs. And yeah, how did we do on this? Well, because we had HDC, we can see how we did. So this is the measure data over time, which is our favorite thing in QI. Heart failure prescribed 3 or 4 of these fantastic 4 medications. So you can see the clinic data over time for one of the clinics where this project was done, and you can see, you might think these numbers are pretty low, but if we look at the other lines, it's even much lower. So you've got clinic data, health authority data, all clinics and division data. So the idea here is we can actually see how our efforts have resulted in some improvement. You're seeing in this particular clinic, there are a higher proportion of clients on optimal therapy, or a measure that's close to this idea of optimal therapy compared to the broader groups. All right. So that's one example. Now, with things like cervical cancer, we know that we can do PAP screening, or now HPV testing for cervical cancer screening. Up in Quadra Island, this is Dr. Stephen Hughes and his clinic team, including wife. So they were looking at their PAP screening rates using HDC and thought, oh, maybe we can do better. So I think they ended up doing a bit more of an old-fashioned intervention, sending some personalized letters to their clients who were overdue for screening. And again, you can see into this black box to see how are we doing, right? So you can see Dr. Hughes' data over time, the PAP, the cervical cancer screening rate, which we're updating the measure to include HPV testing as well. You can see how much better he's doing compared to his area in general, and then of all clinics, right? So now we're able to track improvement over time. I think when Dr. Hughes and the coach working with them showed the staff these results as well, they really felt better about, maybe all those paper cuts and licking envelopes and things. So, that motivation of seeing that they're getting the outcomes they wanted. Third example here. So where is it? I think this is Fernie and Dr. Shelley Forrest. So looking at diabetes, so remember this woman, the idea here is she's having a heart attack, of course, at a higher risk of this in uncontrolled diabetes. So yeah, the Rocky Mountain Health Center. Yeah, I liked the picture of the clinic here with the nice mountain in the back. It's quite fitting to the name. So they decided to hire a chronic disease management nurse, and their first focus was specifically diabetes. And here you can see the dramatic improvement of, people getting their A1C test done, right? So for Dr. Forrest clients, you could see it was quite low, the proportion of people who had it done in the past 6 months. Well, guess what happened around 2021, Q2, Q3? They brought in this chronic disease management nurse, and you see it shot way up and now doing better than clinic overall and their area and all clinics. So that's basically it, right? This is what we're able to do with Health Data Coalition with the HDC Discover app. We're able to look into this traditional, what's been a black box, and gain insights into how things are going for us in primary care as we're all trying to improve it in different ways. So I could probably go on talking forever about the ways I see this as potentially useful or already useful, but I think we're instead wanting to leave this to a discussion. Just a bit more about coverage. We've got about 2,100 users on HDC Discover right now. It covers about 1,200 primary care panels, about 350 clinics. We can cover 80% of the EMRs at the moment, and working on kind of capturing the other the other 20%. So that's been a lot of work over years, making the adapters. So we're comparing apples to apples. And if you've worked in more than one different EMR, you know how drastically different things can be recorded, and this whole interoperability issue. So we're pulling stuff together, and pretty good coverage here. I don't know if anybody has heard of MSPQI, the Measurement System for Physician Quality Improvement. So there was this initiative where we had folks coming together saying what would be good quality outcome measures for primary care to have. A lot of the ones the Primary Care Measures Working Group came up with HDC does have, right? So we've got these measures available, even though that MSPQI project is now defunct. One of the learnings from it was these are some important measures, and HDC, we're happy to say we have these measures available for primary care docs. So I think that's about it from me. And we'll move on to our discussion. Maybe we could take a few questions off the top, or if Gail or Kathy wanted to add any commentary. Yeah, why don't we do a quick check-in for questions, or if Gail or Kathy want to say anything.
I think you captured it well, Cole. As you say, we've got lots of examples of different areas people can look into.
One comment I wanted to make, Cole, is that I don't know was clear to the audience is you mentioned primary care clinics, and just to be clear, because you talked a lot about family docs, but I want to be clear that there are also nurse practitioners who
Amazing
are engaged
point.
with
Yeah,
HDC,
yeah.
and looking at their data and leading teams to do so. And there was another piece, your one about EMR coverage. Sorry, were the two on the bottom in the black box, TELUS and
What's that other one?
ME?
Milo?
Those-
Mile from Medfar, yeah.
MYLE, Mile?
Mile? Okay. And those ones are still
Not
under-
connected.
Unsupported.
unsupported. Okay. But we have 80% EMR coverage in
Yeah.
the province, which is
Yeah.
great.
Yeah, and certainly great point about nurse practitioners and then teams, right? Like I'm in a clinic where I care much less about my individual measures versus the team, because we do share so much of the care, and that's the leverage point for all of our improvement work. I think it's not what I'm doing by myself. Yeah. All right, so any other questions?
I see no hands right now.
Okay, perfect. So
Okay.
in terms of the breakouts, I think we've got lots of time for these. So we've got one HDC person facilitating and one note taker in each room. And I think we're just gonna divide the rooms up evenly. As I'm happy to see at the poll at the start, we have a good mix of folks. So I want you to, instead of going into a room where it's just the researchers talking with each other and the education folks, I thought it might be better to mix people together today, and do the same questions in each breakout. But you, of course, bring your unique perspective on this, right? So if you're in research, you can think specifically about how these intersect with your role in the system. So about 10 minutes, maybe record some ways, potential uses for HDC Discover, potential benefits. So I mentioned one potential benefit is like motivating the team, right? Dr. Hughes showed the team the improvements, and they felt motivated, recognized for all the hard work they were doing. So maybe it's good to write things down for a minute or two and then share out. It's a good approach. So about 10 minutes of that, 5 minutes to talk about how different roles on the team, whoever it is, physician, nurse practitioner, nurse, MOA, OT, PT, whoever, how might they be involved in this sort of work? And then because I'm a QI person, I always like to have a question that's like, okay, what are the small steps where I can take some action? What's safe to try? What's something where I can get the ball rolling on this to start using HDC or some approach like this in the practice in a team-based care setting? So these are the breakout questions.
Thanks very much, Cole. You've taken over my role, so I'm glad that maybe we'll invite you back for our next TBC at UBC event. That was a great outline. Before we jump in, or before we randomly distribute you across the 3 breakout rooms, for those who may need to sign off and go on to other parts of their day before we all come back, there are a couple of things. One is there will be a short evaluation that we send to you via email after the event, and we do appreciate any feedback for the event, and so that we can improve for our next one. And then the second is that we are planning the next network event. It will take place in May or June. We're just trying to solidify some dates. But we're going to send an email through the network to all the network members. And if you have not yet signed up to the network, the link will be in the chat so that you can do so and be sure to join us for our next event. And now, as Cole has nicely described, there are some questions, and we're going to go into our breakout rooms and have some further discussion.
The conversation that happened in each room.
Sure, I can start out if you like. I think our room, we talked about bringing the patient into this. There was some interest in, this being of value to the patient to know all the hard work that is going on in primary care and some sort of insight into that, including patient-reported outcomes and some work going on nationally on standardizing that work, which would make our job a lot easier. And also kind of completing that journey to get the hospitals involved as well, so that you got a complete picture of the continuity of care. I think that would be our highlight.
Thanks, Kathy.
Maybe I'll jump in then for our group.
Thanks, Gail.
You bet. I think I would say the highlight, I'll maybe take one of the last topics of, small steps, encouraging residents to use HDC Discover for their CQI projects. And I think a couple of us had remarked how, the enthusiasm coupled with the curiosity, and it's such a great thing when it comes together, that it creates excitement within and invigorates a clinic. I appreciate Belinda. I don't know where she is. I'm trying to look for her. She had stated the same thing. Who would have thought data would do that? Who would have? Huh? That's insane. So I thought that was a great way that our room had left it. I'm not sure if Christy might have anything else that she'd want to add, but it was a lovely, I agree. Who knew data would be so, to create so much enthusiasm.
Yeah, I think just like in Kathy's room, the engaging the patient in this, engaging learners in this, it really, to me, I think forward to a learning health system, right? And we're all involved in trying to improve things. And this is just the data is that provides us with that opportunity. So.
And that brings us to room number 1.
Yeah, so maybe Ben, I'll say a few things and then you can tell me what I missed. I think Lee, so we heard about some measures being done around maternity care, and then noting, oh, HDC doesn't have any measures on this yet. And so the idea that if you do have ideas for other measures that we don't currently have, we are certainly receptive to these ideas, and if we can make a case together for the utility of additional measures, that's part of our work at HDC. We can't do every measure under the sun, but we want to really give people the measurement tools they're after. Also with that maternity topic, it was around like resource planning. So they had used the data to figure out, okay, what resources do we need? That's a key function of HDC data as well, especially if you're able to make groups. So we can make groups by, say, a PCN. We can make custom groups where we pull in all these clinics into one aggregate, and then you can see the measures for that aggregate. And then you might have a PCN-wide pharmacist doing a QI project, and you can see that measure for the whole PCN and not just individual clinics. So I think that was a key thing to note. We had Hui in our group, who was he's been I think a champion for us before, and is recently having another look at HDC, and we talked about how we might get back into things. He's going to connect with one of our CSMs, David. It just talked about how he and his team might take a look. So say they have workflows about, a team member getting the blood pressure or weight done before they see the doc. And so we have measures in HDC to see, okay, what proportion of the clients actually have a blood pressure documented. So that measurement can become useful that way. What else did we talk about, Ben?
I would just note you had mentioned new measures that people can get in touch with the team, I guess through the HDC website, but that is a welcome suggestion for new measures, and that one of the values of having the system is, in the established measures, you can see how you're doing before you decide to where you're going to focus a particular improvement. And you've got that baseline data, hopefully in good shape to make a change and monitor the effect. When you have new metrics, there's a process for getting that measure into a place of good data, but that's a value that we talked about, of being able to see the improvement with good baseline data.
Yeah, and we also talked about, I think the other thing that came out a few times was the idea that the other team members could have access or be delegated to look at the data, right? So we do have some certain user accounts, like a division family practice person can look at the data for their division. But also within a clinic, I think Kathy often talks about having the clinic manager looking at a lot of the data, and maybe they're even the primary person with the approval of the medical director, pulling up the data for their clinic and maybe presenting it at the monthly staff meeting or whatever it may be. Yeah, and just so we did have some questions about what kind of different user accounts there were, and a specific question about like naturopathic physicians that we'll have to follow up with offline, because I'm not sure the answer to that. But yeah, it will definitely be responsive to an email about that. Yeah, Lee or Ben, did I miss anything else there? Yeah, I don't think we really got through all the questions either. The time flew by.
I love this idea of being able to look at the data, like this sort of higher level data, and see. So let's say you change a workflow process. Let's say you shift a task, as you said, the blood pressure taking, for example, and to a different one of the team members. And then you can look at the data and say, did that make an improvement? And if it didn't, then you can adjust that workflow again. I love this idea of and thinking about it as a team, not necessarily just a provider trying to improve patient care outcomes, but actually the team processes and the team efficiencies. You could capture those as well. And so not just learners' enthusiasm, Gail. It's like, I get all excited when thinking about the opportunities that this presents. Chris.
Just building on that idea, Christy, I kind of wonder if it might be possible in the future to say, you know, if I'm in a clinic and we've spotted that we have a particular problem in a particular area, can I look at comparisons with other areas and say, well, they're doing better than me, and then filter it down to people who've taken initiatives for that particular issue who are now doing better than me, and then look specifically and see what measures they tried that helped. So instead of me searching for what could I try, I can look at what people have already tried and had some success with and prioritize those as things I'll try first.
Yeah, that's an amazing idea. I think we have talked a bit about how we can link people together who are working on the same thing. I think at this point you can compare to other aggregates. You can say like, okay, me compared to everybody else in my health authority connected to HDC, how am I doing? I can't really directly find the people who are working so say my blood pressure follow-up documentation sucks, and I see a few clinics have it very high. I wonder what they're doing. Well, I can't figure out who they are unless they've already been like sharing with me. You could ask the HDC team because sometimes we would know if people are doing certain initiatives, or there's like provincial quality improvement databases to track projects through things like shared care or PQI program. But yeah, I think there's opportunity for what you're talking about. And in our measures, we've started to link more resources to things like GPAC guidelines for blood pressure and that. And we do have the idea to also link to more, practice improvement modules and things like this. It's not in production yet, but that's certainly on our list of ideas.
I know it's currently beyond the scope of HDC to do those sort of linking things, but it makes me think, you identify the clinics, you let them know, you're an example of best practice in this particular metric. Would you be open to like tick this little box to say I'd be open to sharing how I approach this particular metric? Just as I say, I know it's beyond the scope of HDC, but I'm trying to think of that. I think that would be like if I was invited, and identify. So if the first part is identifying me as best practice in something, woohoo, then I'm okay. If I'm worst practice, I'm not interested in sharing. I'm ashamed and I'm running away. But if I'm best practice in something, you might tick off and say, yeah, I'll share how I'm approaching that with another clinic who's struggling.
Yeah.
May I add though, because Christy, something that you said though, and I'm gonna toot a little bit of Cole and Kathy's horn here. They've been running small group learning sessions, like small groups together, where I loved that at the beginning of the initiation of these groups, Cole, you basically looked at everyone and said, hey, we got to all get comfortable that sometimes you are going to be the one at the top of the heap. And other times you may not be. And we need to just get comfortable with that. And so, Chris, I think that, to your comment about, hey, who can I reach out to find out? I actually think that through Kathy's work in the community and trying to create these kind of regional, getting them started, kind of small groups, you're probably one of the ones at the top of the heap for some of these things too. So while you might be searching for someone to help you for something, you might actually be the one to help someone else first before you know it. So it's interesting because we feel like we need to go out and sometimes search far and wide for, someone that might have, ideas. But I actually might, and I think through our experience, it might be closer than you expect.
Within your clinic.
Just getting the group together. Sorry, Kathy, go ahead.
Yeah, within your clinic sometimes. We find at lunches, it could be just a miscommunication of an error, like you thought you were coding it for that, but it really wasn't. It was just a dyslexic number thing. Or, you're surprised you're in a group, somebody is surprised they're at much better than their colleagues at screening. And it's just an organic exchange of, well, how do you get your patients in? What are you doing that I'm not doing? So it's very nice to see that organic kind of collegial learning, peer-to-peer learning, just happen by looking at the data. It's really just a thing that generates discussion.
Yeah, the Peloton instructor I hear often says it best. It's like, don't compare to the other people in this, but compare to yourself yesterday, right? Like that's much more important. It takes into account all the context, right? So if you work in a clinic like mine where it's like complex, marginalized, vulnerable folks, of course my measures are going to look different than a very different looking patient population, and that's okay. It's not to say that some of these people with high measures can't be benchmarked to like go out and be curious to say, hey, your numbers are so high, like what are you doing? I think that's still a useful exercise, but we got to keep in mind much more important to use this as a learning tool for yourself and look at your own measures over time.
I think that's where the issue of a scorecard, can be a little bit challenging because it
modify every
the
time
term.
Gail says scorecard, I correct her, and I think it's finally it's ingrained now because she corrects herself. But we talk about a quality planning tool, and Ben actually in our breakout brought up this sort of thing, where even before you decide what you're going to do QI on, it's good to get a lay of the land and say, for all potentially important topics, how am I doing? And then based on the data, I can focus my QI efforts. And so that's the quality planning piece, which others may say like an initial scorecard. We try to take some of the judgment out of that, like you're doing good, you're doing bad. It's more like, where are my opportunities to do improvement work to have the biggest impact?
Can I ask a question? So Kathy Cole, when you've gone out to different providers or clinics, have you noticed, I don't know if you've had the experience where you've seen clinics using it as a team? Like sitting down and discussing their metrics as a team and looking at it that way?
We have on a community level in the Kootenay Boundary area where there are a number of kind of QI keeners, and they have worked with their division people to they've surveyed membership and said, yeah, we're interested in these topics. And we've brought people together called Data, Dine, and Dialogue. And, just a chance to sort of, again, share those practices of what people are doing in clinics, and organically things have come out, and also a way to vet system issues that are seen as barriers to them getting some jobs done. And there are a few clinics there that I think are regularly doing it, prompted by our field team there, who was quite active. And this is kind of the way I see it growing, a few keeners, getting them together and then bringing that back to their clinics to sort of get that critical mass of people understanding the value of data.
Nice. And I see in the chat, Prince George has data parties. That's
Yeah.
great.
Yeah, Tamara's a longtime coach up there and doing some good work.
I just wanted to mention that coming from Alberta, I did this work for orthopedic surgeons. They really did like the scorecard approach because they were competitive with their outcomes, and so it really does depend on who's
the audience,
who who the audience is. So,
Yeah.
but I do agree, like we would set, we would give those kind of numbers to, there wasn't that many orthopedic surgeons to do that with, but they like to be competitive with each other. But also it's nice to just compare next to the mean of things too, to just be able to set, kind of see if you're, a standard deviation over, you're doing a good job and you're outstanding at something, or if you need to, change that. And I think that's a pretty common way of doing things, at least in surgery and in, trauma, that kind of area where they've been doing that kind of work for a while.
Yeah, that's
Yeah.
a great point. And then one feature of Discover we didn't show is you can see a distribution graph. So in addition to the data over time, you can see for the latest data point, you could see your own bar graph. So say I only have like 10% A1C done in the past 6 months. I can open up the distribution graph and see like, oh my 10%, like it looks like 90% of clinics are doing better than me, like on that. So that's kind of getting what you're talking about. We always worry about that scorecard issue of like, okay, is the surgeon then going to stop seeing the complex clients just to get their numbers up? So that's where you get into the whole like perverse incentives and all that.
Yeah, and your different populations comes up there too.
Any other questions for the panel that we have them here? Any questions that didn't get answered, or things you thought about in your breakout that oh, Chris, again. Yes.
All right. I'm just curious how the Health Data Coalition, how your work aligns with the CAI Connected Care project and the data standards that they're working on.
The connected care, yeah, I can speak a little bit to this. I'm not sure specifically in terms of the connected care project, but we've been working with CAI in terms of the oh my goodness, Pan-Canadian primary care. What is it? It's basically the patient profile. So what kind of, standardized data would we want to be able to see to go through a, for transmission that could be used and could be portable, if I could. So we're involved with that group. One of our team members is on a working group, and we salivate of potentially getting to a point where we could all have a similar standard of, when I say standard, more so from a data transmission perspective. To give a little bit of background, we currently support 6 different EMRs, but the data doesn't always look the same. And you'd think even the lab data that comes from the same health authority lab that goes through the EMRs and then comes to us doesn't always look the same. And the same lab result across the province with different lab providers and the different way it's just delivered to us does not look the same. For instance, we have hemoglobin A1C is delivered to us over 200 different ways. So Chris, you get me so excited when we get to talk about this boring stuff, right? Because this is where I believe our value comes in. We map all of this so that we can look at apples to apples. When we're given a fruit salad, that's my favorite saying, we are given a fruit salad of data. And we sometimes have to pick out the apple out of what we're given to make sure that we can do the comparison. And that, I think, is what the value we bring to the system right now, and what I think makes it easier for our clinicians to be able to look at this and to be able to use it as they see fit. We currently do not have a standard consistent across all of the EMRs. While everyone is working towards that standard, it is not fully implemented into our system. And so this is where I love that we're trying to do this at a national level, but we are not yet seeing that happen. There's some movement. I do want to stay optimistic. There is some movement, but we got a ways to go. If I were to look at the different, and again, it's just not by EMR. It could also be by lab. It could be, different data sources also need to lean in to how to send in a certain format so we all understand what it is, not just EMRs. So that's Chris, yes. So we're the quiet ones kind of in the back trying to cheer for this and not be overzealous on this. But yeah, I think it would help reduce that mapping exercise in a huge way. So yes, we're involved. Let us know if there's ever anything else that, you think we could be more involved with, because we do like talking about this, because we see the larger impact of trying to make this more streamlined and easier. Great question. Narmina, I saw you with a big heart. I hope you're in data.
I'm not, but when you spoke about this, I was like, because I've been wanting to get more into this, and it's true. Especially when you start trying to coalesce. I mean, reading a study in it of itself, you see how all over the place things are. And if we're in a province where we're trying to gather data of our greater province even, or nationally, it helps to be able to collate things so that we can actually see patterns. Right?
I agree. So yeah, I'm going to go on a little bit of a tangent. I hope you don't mind, but when we talk about the burden that the EMRs with the data presents,
exactly.
One of the pieces, I mean, we've got examples of this where, yes, we need to ask our clinicians, where they are the source of that data, to please enter it in, consistently and accurately where you can. But I also believe that we've got many examples where we should be asking the larger system, hey, if you're wanting me to do more screening of X, I need help for you to actually give me the result in a readable way that my EMR can actually accept it in discrete data terms, and we can actually use it to prompt. This is where the hope of technology to be able to support and help, right?
Yeah.
We've got a lot of examples where, right now it's kind of broken, and we've relied for too long on our primary care clinicians because they've got to read through the report, but then we've relied on them to copy and paste it into a discrete data field. And that's not good enough. I don't think it's good enough. And that's where I think we've relied too hard on kind of our clinicians that have done this for so long, but it's not good enough. So, and I think that's some of the administrative burden that I would hope that technology could actually relieve for our clinicians. Again, small but big, small but big. Sorry for going on the tangent. Let me know if I ever want to talk about data standards. I'm here for you.
I'm sending a message to you right now.
Perfect.
Okay.
Can I
Yeah, Barbara, I saw you unmute. Go ahead.
I'm very interested in that as well, because I help on the wellness platform side and this interoperable standard that's coming. So I too will be sending you an email, because we really need to integrate these and make sure some of these connections happen. Yeah. Thank you.
Yes, please.
Okay.
Yes, please.
Any other questions pop to mind?
I wonder, Christy, just before we go on, there was something that Cole asked in our group that I keep thinking about. And the prompting question of the conversation was, when we were talking about team roles, the question was, should it be only the physician responsible? And I think about the environment of team-based care and the environment of interdisciplinary teams. And I, not to answer that question specifically, but to build on that question with how can we continue to grow so that it's not assumed that the physician is responsible.
Or MRP. Let's make
MRP.
sure that we're talking NP
Yes.
right now.
Yes,
who
thank you.
Yeah,
the MRP in these in the team-based care clinics, and so that's one of the hanging questions I'm leaving with today. And then the other question is, the lens is turned inward towards the clinic, and what do we see and what do we think the community needs based on the data that we see? And I wonder also about involving, so we talked a little bit about bringing the patient in, but actually engaging community. So if we think about, we talked about reflection at the level of the individual, at the level of a practice or multiple practices over a PCN. How do we engage a community population, even for ideas of what's important to you in this community? And we know that there's very different populations, even within primary care. So the downtown east side is going to have a very different priority set as a community of people than maybe some of our Gulf Island retirement population heavy communities. And so what is important? How do we have conversations with community around what do you want us to look at? What can we look at together? And what can we build quality improvement around together within this community?
The great points there, and I think you're making me think of this more, this idea of quality planning more. So, I recently completed a course with the Institute of Healthcare Improvement, like Chief Quality Officer course. But a lot of what they talk about is whole system quality. So instead of just doing QI, this is embedding quality and making it like the organizational strategy. So you do quality planning, quality improvement, quality control, and then you look at your culture and your infrastructure and all these and make sure they're conducive to doing quality well. But that quality planning piece is really about what do my customers need, and like, what in their eyes is a quality product, right? And so when we're prioritizing what we're going to focus on for improvement efforts, a big piece of that prioritization comes from input from the customer or client. Customers like the American kind of term for it, but it's the same idea in other industries. Is you need to know what's important to the user, the customer, the client.
Thanks, Cole. And thanks, Lee. About your first comment about MRP, we are the Gateway to Team-Based Care project, eventually a center, will actually be looking at attachment to a clinic versus attachment to an individual as a direction that I don't know if people are familiar with Jane Philpott's work and ideas about the community clinics where you automatically are assigned to a clinic when you move into a community, and this concept of not being attached to an individual and then being attached to a team, a primary care team. And so I'm thinking of that question as well, and how we shift that. And then that actually in my brain leads to that other piece about what does the community think about that? And that transition from having a relationship with an individual provider to having a relationship with a team. I was going to say a clinic, which is very different, but with a team within a clinic. Okay. I didn't mean to get the last word, but I see that we're at 25 after. And I really want to thank Cole, Gail, Kathy for joining us today and sharing about HDC. I know that there was links in the chat about to learn more about HDC. I'm sure that all three of them would be interested in you reaching out and connecting if you have more questions or just want to learn more about it. So thank you again. Thank you to our also our note takers. We will summarize the session today and circulate it. A couple more announcements that I didn't mention before the breakouts. One is that we are hosting a Where is the Patient's Voice conference November 12th to 15th. Abstract submissions are still open, I think. And it really is patients' involvement in education, as well as research and health system transformation. And then the other thing is we are hosting a day-and-a-half event, Bridging Research and Action, on May 15th and 16th. And the event will take place across both campuses, so UBC Vancouver and UBC Okanagan. And there will be a virtual option as well. And registration is open and the link is in the chat. And again, we will send a evaluation. Please provide us feedback so that we can continue to improve. We will also circulate the next event date once we've got it settled in May or June. So thank you very much. And I hope you all get a chance to get outside for a few minutes to enjoy the sunshine before it sets.
Thanks, Christy.
Thank you.
Thank you so much.
Thanks, everybody. Good
Thanks.
discussion.